Hello everyone. For the Mental Health Service System Review, we chose to research traumatic brain injuries in veterans. Between 2000 and 2019, 413,858 service members and veterans were diagnosed with a traumatic brain injury. Roughly 80% of all diagnoses are classified as mild. This is also considered a concussion. TBIs can be classified as mild, moderate, severe, or penetrating. The most at risk of experiencing TBI are enlisted males between the ages of 18 and 24. Research also suggests that anywhere from 11 to 23% of deployed service members will be diagnosed with a traumatic brain injury. The DoD and CDC track military TBI diagnoses quarterly as well as yearly. So why are the state-specific numbers you see below so outdated? As you will all see throughout this PowerPoint, there is a large and ever-expanding system in place to provide care for these individuals. With the CDC's help in tracking injury and the numerous DoD-aligned facilities, state-by-state data may not be an accurate representation of the overall magnitude of the problems this population faces. Service members are also unlikely to be stationed in their state of residence, and if they are, it won't be for long. It is more effective for the DoD and this service system to track incident reports rather than the location at which they happened or where the service member is from. National policies affecting this service system include the Traumatic Brain Injury Act of 2018, which provides needed funding to state-level agencies and is also utilized by the CDC for data collection purposes. This act aids in such state activities like screening to identify individuals with TBI, building a trained TBI workforce by providing professional training, providing information about TBI to families and referrals to appropriate service providers, as well as facilitating access to needed services through resource facilitation. SBGs like those seen in Kentucky and Georgia cannot appropriate funds for primary injury prevention or providing direct services, but they can utilize these funds however necessary to educate on the subject of TBI symptoms, causes, and treatments. While this funding is not exclusive to military members and veterans, the state agencies who receive program grants may be able to offer services and resources for these individuals outside of the VHA, VA, and DoD. The TBI memorandum listed below is an initial point of TBI detection for those individuals in military service who may have experienced injury and aims to prevent these occurrences from going undocumented and properly treated. The first step, the Military Acute Concussion Evaluation, or MACE for short, is required for all soldiers who have been deployed to heavily combative areas overseas, and in cases where trauma may have occurred on the home front. For many, this is part of a routine physical health assessment. This memorandum sets the stage for how treatment and symptom management will progress for each person that receives a score indicative of a TBI. The MACE is often given in conjunction with physical exams, neurological assessment, as well as brain imaging. Another national policy that is directly affecting Kentucky is the Maintaining Systems and Strengthening Integrated Outside Networks Act, or the MISSION Act for short. It was put into place June 6, 2018, and its latest updates were added on June 6, 2019. The purpose of this act is to increase the availability and access a veteran has to community care, including TBI patients. This is important as Kentucky is a predominantly rural state. It is estimated that 4.7 million veterans are residing in rural areas across the United States, and veterans who live in rural areas often have less access to care, such as private physician practices and hospitals. Specifically, the law would require access to community care under the following circumstances. If the VA does not offer the care or services the veteran requires, the VA does not operate a full-service medical facility in the state where a veteran resides, the veteran is eligible for care in the community under the 40-mile rule in the Veterans Choice Program, VA is not able to furnish care within the designated access standards established by the VA, or a veteran and the veteran's clinician agree that community care would be in the best medical interest of the veteran after considering certain criteria. If the drive time to a VA medical facility is 30 minutes, average drive time for primary care, mental health, and non-institutional extended care services, if the drive is an average of 60 minutes for specialty care. The ultimate goal is to provide better access to a veteran, including a veteran with TBI, so that they may receive more resources and treatments close to home. This is particularly important with TBI patients as they face unique challenges in their care needs. Kentucky only has 18 VA clinics and 11 VA urgent care clinics. These clinics are serving the entire state of Kentucky. Given the fact that Kentucky is predominantly rural, this translates to not only exponentially long waits, but long drives to attend the appointments. Because there is no single discipline that owns the care of a TBI patient, the outpatient civilian setting may feel like fractured care. This becomes even more stressful when a veteran has trouble not only with access to the private sector once released from hospital care, but with access to veteran benefits he or she has earned in service. Additionally, TBI patients that are reliant on traumatic brain care in the state face even longer drives. The Mission Act will make it possible for TBI patients to visit care providers much closer to home if deemed appropriate by their primary care doctors and approved by the VA. TBI patients and families must learn to navigate insurance policies, transition from the structure of military life, deal with providers, keep up with appointments and medication, and try to return to a new normal at home. Navigating these tasks becomes difficult. For example, those that experience cognitive or behavioral impairments, these tasks may seem nearly impossible. The Mission Act seeks to make these services more easily available. The Mission Act is still new, and more suggestions are being made on how to improve it. In Georgia, for example, wait times have gotten even longer. The TBI caseworkers or social workers will be responsible for locating and navigating new access points to these newly available services, including clinics, urgent care, and behavioral health centers. Social workers will also need to investigate what services their TBI clients are gaining throughout the Mission Act, losing through the Mission Act, and how to advocate for policy measures moving forward. Georgia relies on its 3 VA hospitals to operate as hubs across the state in carrying out VA national TBI care regulations. Georgia clearly needs further VA healthcare expansion in order to care for veterans with TBIs. Lastly, veterans must meet eligibility criteria, which is somewhat restrictive, to enroll in VA healthcare, as it is no longer an entitlement to be allowed to use VA facilities. The 9 active duty bases are to provide TBI screening to military members in Georgia upon coming back from deployments, especially combat zones. Through the VTC programs, Georgia veterans that have entered the criminal system or are in danger of doing so and suffering from TBIs can receive assistance outside of the VA and DoD facilities. The VA and DoD are working together to ensure as many military members and veterans are receiving TBI screenings and specialized treatment to recover from TBI. Social workers need to be aware of all resources available between the DoD or VA to be able to assist clients in linking to individualized treatment, to include knowing options outside of DoD or the VA if wait times are too long. Nationally, VBA and VHA rely on federally budgeted money to operate the healthcare and compensation programs. DoD chips in to help fund research for mild TBIs alongside the VA. As you can see, billions of dollars are being allocated towards mental health services, which TBI falls under, as well as disability compensation. As mentioned in the previous slide, all VAs are federally funded. Kentucky specialty courts are provided through grants from the Federal Bureau of Justice Assistance. There are no mentor TBI recovery programs in Kentucky. The nonprofits, like the Brain Injury Alliance of Kentucky and Veterans Club, operate through diverse investors that provide donations. Again, all VAs are federally funded. The VTCs are a mix of state and federally funded programs depending on the county. The nonprofit mentor programs receive little in the way of VA federal funds due to the local VA hospital fund restrictions. SHARE receives pennies on the dollar from the VA to fund their program. Emory also has the same issues with VA funding. So you are a traumatic brain injury in the theater of war. Now what? Veterans that have sustained a TBI will typically begin treatment with an evaluation and acute rehabilitation, and then progress on to post-acute care in their own community. There is no one discipline that can take full ownership of the care of a soldier that has suffered a TBI. TBI patients will be assessed by each of the following professions at a polytrauma clinic to establish a thorough diagnosis: physical medicine and rehabilitation, neurology, psychiatry, behavioral health, neuropsychology, audiology, optometry, ophthalmology, physical therapy, speech-language pathology, occupational therapy, and rehabilitation psychology. A TBI case manager will then help to coordinate care for the TBI patient, and the vet will go through the TBI polytrauma system of care. Those that have mild TBI will be released into outpatient care, while those with more severe TBI may require longer stays in a polytrauma hospital or require in-home assisted living or even a move to an assisted living facility. Those with mild to severe TBI will likely be in need of organized and coordinated care across multiple disciplines for a range of issues. As TBI patients recover and transition closer to their homes, a polytrauma system of care provides a continuum of integrated care providers through 5 polytrauma transitional rehabilitation programs, 23 polytrauma network sites, 86 polytrauma support clinic teams, 39 polytrauma points of contact located at VA medical centers across the country. PTRPs provide specialized emerging consciousness programs, comprehensive acute rehabilitation care for complex and severe polytrauma injuries, outpatient programs, assistive technology evaluation and training, and residential transitional rehabilitation programs. PNSs provide inpatient rehabilitation for those transitioning closer to home, comprehensive outpatient TBI evaluations, and a full range of outpatient therapy services. PSCTs provide interdisciplinary outpatient rehabilitation services for veterans and service members with mild or stable impairments, polytrauma, and TBI. Services include comprehensive TBI evaluations, outpatient therapy services, management of stable rehabilitation plans referred from PRCs and PNSs, coordinating access to VA and non-VA services, and follow-up care and case management for ongoing rehabilitation needs. POCs is identified in every VA facility that is not otherwise designated as one of the PSC components described above. The PPOC ensures that patients with polytrauma and TBI are referred to a facility and/or program capable of providing the level of rehabilitation services required. PPOCs commonly refer to the PNS and PSCTs. The above chart shows all of the polytrauma sites that are available in the wiki. These systems continue to coordinate and collaborate with one another as the TBI patient makes the move home. For residents of Kentucky, the Lexington, Kentucky VA Healthcare System is a part of the polytrauma network of the VA Mid-South Healthcare Network. The facility is comprised of 2 main campuses, the Troy Bowling Campus and Franklin R. Sousley Campus, with VA community clinics located in Berea, Hazard, Moorhead, and Somerset. The Lexington Polytrauma Network site is one of 23 facilities in the country designated to provide long-term rehabilitative care to veterans and service members who experience severe injuries, including brain injuries, to more than one organ system. Georgia, in comparison to Kentucky, has 3 polytrauma centers, which are all part of the Augusta Polytrauma Network site. These include the Charlie Norwood VA Center, the Carl Vinson Medical Center, and the Atlanta Medical Center. The Augusta Network is one of 23 facilities in the country designed to provide long-term rehabilitative care to veterans and service members who experience severe injuries, including TBI. The range and scope of care is much more available in Georgia than in Kentucky. Problems happen when there is a breakdown or a complete lack of communication between all of the interdisciplinary services the TBI patient may be using. TBI recovery is often long and requires services to be administered in their home and within their community. It has been shown that TBI patients report gaps in care only 1 year out from their injury and hospitalization. Take a look at the list of problems a TBI patient could run into, such as waiting lists, various insurance providers working with the VA, and so on. This happens despite the fact that these polytrauma centers all have TBI case managers on staff. These case managers can be social workers or nurses with specialty training in TBI issues. Think about what you feel needs to be done differently. TBIs have been and remain a pervasive problem for U.S. military service members. The DoD, VA, VHA, and other agencies have continued to take steps in aiding in TBI screening, diagnosis, and treatment, but much work remains to be done. Without sufficient policies, funding, and comprehensive service delivery, we as social workers cannot effectively assist in lessening the burden of combat and injury among our nation's heroes.